You shoot, yes, and you.
It's like getting on the bus.
Yeah, yeah.
Yes.
And the name.
The name, I've already followed you on LinkedIn. Don't worry, I'm already in your life.
Oh, right,
Yes, yes.
Right.
Very, very good presentation yesterday.
Thank you. That was so fun. And
My phone is very good.
really? Yeah, you know. Well, and you know, I love the way it means. Okay. Pardon me.
Never. That's correct. That.
Avant que Madame parle, je vais interpréter pour vous les francophones. Et quand vous parlez, on va faire ça en consécutif. Et consécutif, vous explain how we're going to work this interpret. Consécutif, ça veut dire, vous dites une ou deux phrases, je traduis. Encore une ou deux phrases, je traduis. Parce que ça sera... Oui, pardon, une.
Parce que sinon, ça devient compliqué. Tu as le micro.
Merde, un peu vite, pardon.
Tu as un micro et c'est ta chaise. A dit.
A dit-il?
Non, pas dit.
Si elle te dit quoi faire, son mari, c'est un carreau à la maison.
Non, mais bon. Mais tu as le micro.
Pas de problème.
Tu me casses?
Je n'oserais pas.
Welcome, everyone, all of you here in our beautiful downtown library in Minneapolis, Minnesota. Those of you who are joining us from around the planet and from other parts of our state. This is a special evening, special because of our wonderful guests who are here, special because it's the first time we've been able to gather since that March 2.5 years ago now, when the COVID pandemic made us shut down. And over these many, many months, we have not been able to meet in person. And tonight is our very first public event back in person. We don't know what the future will bring, but we know that we want to be with each other. We also know that we have many friends that we've made and who deepen their relationship to Global Minnesota around the world that are watching this streaming live tonight, or possibly they're watching it in the future on our archive site. But this occasion this evening is also at a time when the topic, the specific topic of disease prevention in Africa, but the general understanding that we are now reached a new level of understanding about the global nature of some diseases and the global nature of the demand of the Sustainable Development Goals for universal health care. We are using today's event as a next step in the larger picture that Global Minnesota has been working on for many years, reaching our mission of connecting Minnesotans to the world and the world to Minnesota. I had the great pleasure of being with our guests, our international visitors at our state capitol earlier this week. And I said to them, when they come back to visit, there are other places I would like to share with them. I didn't say if they come back, I said when they come back, because I really want our friends who come to be able to feel welcome and come back. But I want to come to your homes, to your countries, to your lands, to your lives. And that's why Global Minnesota is about connecting on a two-way street. For those of you who are new to our organization, and those of you who are joining by Zoom, we're over 70 years old. We're one of the largest World Affairs Councils in the United States. We're supported by members. Many of you watching are here this evening, are members. Your financial support makes it possible for us to do these free events that reach beyond our close friendships into the broader community, statewide, nationwide, and globally. We have partners who make it possible. We're especially remembering them tonight, this first time back in person. The Minneapolis Central Library, that's the one that we're in here. Friends of the Hennepin County Library, so that's the citizen association that helps support all of our libraries, including this one. And we also have partners who are in our work of public education, really critical components to how we reach other communities. Landmark Center in downtown St. Paul, some of you know, one of our really important partners. Edina Senior Center, Minneapolis Public School, Community Education, Plymouth, the City of Plymouth Library, the Minnesota International NGO Network, Washburn Library. These are all part of our partners. And we were very blessed tonight to have representatives from a number of the organizations that share our global mission here for our global social. So thank you to all of you who brought materials and who brought your mission, your story, your ideas, your experiences into this evening's program. Many of the topics that we tackle in Global Minnesota's public education, we do collectively nationwide, coordinated through the Foreign Policy Association's Great Decisions program. It's something that happens throughout the country. Individuals get themselves organized in a school, in a church, in a community center, in a library, and they tackle 8 important questions over the course of a year in a common voice. It's something like when communities choose a book to read together. These are subjects of high importance in the global arena, and we do this as a way to have a broader, deeper understanding of international issues, but we do it to impact. Our job at Global Minnesota is advancing international understanding and engagement, and we take that work very seriously. Tonight's discussion will give us a taste of some of the work, expertise, professional and scientific experience of our guests who come to us for this part of this week as part of a national tour, a national exchange. We call them professional exchanges, coordinated through the U.S. State Department. I'm really pleased that Minnesota was chosen as one of the places. I believe they've been in Washington, Los Angeles. They will go to Atlanta, where our Center for Disease Control. They're scientists, epidemiologists, infectious disease specialists in their countries, and they brought their experiences and shared those with our community, and they're taking away experiences that they've had here in the United States and they will continue to have. But tonight we get a chance to hear from them some of their perspectives and some of their particular understandings and wisdoms about prevention. And this is a subject that's always a topic when we're in the middle of a pandemic, but prevention is one of the most important elements of public health anywhere on the planet. And we always have much to learn from each other on a two-way street. Our program tonight will be moderated by Dr. Nekes Sederstrom, Chief Health Equity Officer for Hennepin Healthcare. Hennepin Healthcare is our very, very amazing county and region-wide health hospital. It's a place that my wife and I have a very special love for this. It's been very important in our lives in some important ways for us. But it's an amazing place, and their commitment to health equity is one of the elements of our whole community's commitment to equity. And Dr. Soderstrom tonight is sharing her expertise and skill in moderation and bringing ideas together that help us remember and keep a focus on that equity question. Our panelists are part of this larger delegation. I'm sure that I do not have all of these pronunciations right, but I want to make sure that the audience that's watching from distance and also that will be watching this over time knows the amazing people that are here, both in the panel, but in the larger community. Dr. Richard Mugahi is the Assistant Commissioner of Reproductive Health, Adolescent School Health at the Ministry of Health in Uganda. Dr. Kinza Beckenbroom, Supervisory Pharmacist at the Pasteur Institute in Morocco. Dr. Patricia Obuzi, Doctoral Fellow, African Center of Excellence for Genomics of Infectious Diseases at Redeemers University in Nigeria. Mr. Ababo Limazi, HIV Regional Advisor, Togo's National HIV/AIDS Council, and Dr. Sophie Teshi, Department Head Government of the Cote d'Ivoire Rabies Center. If you're watching this from around the world and you have a question that you would like to submit, please do that by sending it to this email, questions with an S, globalminnesota.org. Again, thank you to all who joined us tonight for this rebirth of our in-person programming. Thank you, Dr. Soderstrom. I turn the microphone over to you.
Thank you. Thank you, everyone. I am delighted to be here to help moderate this channel. And I have just a few questions because I know that it's an exciting conversation. And so what I would like to do is start off with a question for everyone, just have you quickly answer, and then we'll get a little bit more into the nitty-gritty, the things that we really want to talk about.
Excuse me, we have some technical problems.
A little technical difficulties, so we'll do a pause.
That's enough? Okay.
Are we ready?
The room's special.
Oh, the room is special. That's, I mean, technology is special. Okay. I think we are ready to go. All right, wonderful. Thank you. So you all have been in the United States now for a little bit. And the question that I have for you is, in this program so far, what has been your favorite thing?
Préféré. Qu'est-ce qui est l'aspect préféré du programme jusqu'à présent? On va commencer avec Judith.
Hi, once again, my name is Judith. I'm from Nigeria. For me, this work experience have been life-changing. I get to see how my colleagues on the other side of the world tackle the problem of infectious diseases, and also learn from them, also see limitations. And one of the interesting things is some of the problems we have are very universal. They also struggle with some of the challenges we have, like a problem of information about vaccine and how to get people out on the other side of the fence to understand how important these subjects are. So it's been, life changing. I've picked a lot of things definitely that I'll take back with me.
Thank you.
Merci, bonsoir. Et je suis à Ballon. Pour moi, c'est l'organisation même du système de santé.
For me, and have a good evening. Have a good evening. It's the organization of the whole medical system.
Et fait qu'on mette l'accent sur les petits détails. Et pour nous, par exemple, dans mon système, les petits détails ne prennent pas en compte. Mais ici, le petit détail de l'état de santé du patient est un élément assez important.
And the extent to which here in the United States, you put an emphasis on every last detail in the healthcare system. That's something which maybe our countries don't necessarily always share.
Et ensuite, j'ai partagé, par exemple, l'expérience de la paire éducation au niveau de Los Angeles sur un programme sur lequel j'ai beaucoup travaillé. Donc, ça m'a beaucoup intéressé.
Okay, so
L'expérience de la paire éducation.
and also the education among peer education that we saw when we were in Los Angeles was very impressive.
Bonsoir, je suis très contente d'être parmi vous aujourd'hui. L'une des meilleures choses que j'ai appréciées du programme IVLP en général aux États-Unis, c'est la diversité des organismes et des organisations, que ce soit publiques ou privées, qui se mettent la main dans la main pour améliorer le système de santé américain.
Good evening. I'm very pleased to be amongst you this evening. And what has interested me the most is the extent to which the public sector and the private sector are working hand in hand to try to provide healthcare and improve the healthcare system.
Good evening. Once again, my name is Richard. I'm a public health practitioner in Uganda. What has really captivated me over this study visit, first of all, is the level of technology that the scientists in this country are able to use and are able to make a diagnosis of any infectious disease in the very shortest time possible. And way back in our countries, developing countries, when COVID broke out, it takes you some time. You have to carry samples from very far and deliver them to a central laboratory. And probably in 3 days or 4 days, that's when you get the results back. So it's very interesting how the systems work here, the level of technology at every state. They are able to have results processed and able to identify the infectious disease. Thank you so much.
Merci. Moi, je suis Dr. Tichisopi Matit. J'ai aimé ces échanges depuis Washington jusqu'à Minnesota.
I am Dr. Matil, and I very much appreciate the exchanges we've had, starting with Washington, D.C. and until tonight here in Minnesota.
Je suis dans le domaine de la lutte pour les maladies infectieuses, particulièrement dans le domaine de la lutte contre la rage humaine. Et j'ai particulièrement aimé l'organisation dans la lutte contre les maladies infectieuses émergentes et réémergentes, associées à la recherche.
I work in fighting against infectious diseases, and particularly working with babies in my country, and I've been very impressed by working on fighting particularly the research aspect around this question.
Et surtout, cette gestion a été faite selon le concept d'une seule santé où les domaines de la santé humaine, animale et environnementale ont été associés. Et j'avoue que ça fait plus, c'est vraiment spécifique et c'est la recherche qui peut faire évoluer le monde.
I'm very impressed by the One Health approach to the animal and environment. Through this and research, I think we'll be moving forward very much.
Thank you. So on to the harder stuff. All of our countries have unique inequities when it comes to disparities in diseases. And we have unique ways to try and address them. What is the most problematic prevention for a specific disease within your country that you personally are trying to address?
Okay, seems like we need to go political. I think, let me speak for my country. We have lack of proper leadership in a lot of things, infectious disease inclusive. And one of the things that has been really heartbreaking for me personally is how things that have to do with human lives and disease outbreak have been highly politicized.
You need to, sorry, I don't mean to interrupt. Do you need to translate?
Not for English, no.
Okay.
Thank you.
So, major issue we have is identifying unknowns. And most times in outbreak condition, because of diagnostic challenges that we have, really difficult to know in real time what is actually going on. And this information is necessary to inform whatever preventive or control measures subsequently. And we have like some populations that are in regions that is not easily accessible. And then even in terms of healthcare, not everybody has like access or is willing to go to the hospital when they show symptoms of a particular infection. So most times before it comes to the people that are doing research or able to know what's going on, there's already a local, outbreak. So there's definitely like not equal access to healthcare. And people are sick, they don't want to go see the doctor or they don't have the resources to see the doctor. And a very practical example was a yellow fever outbreak that we had in the country. And this happened to children, mostly children were affected in that community. And 80% of that population that had that disease actually died. And in that instance, it's really sad because yellow fever is a vaccine preventable disease. Honestly, there's no reason why anybody should die. And we have a very short viremia for that kind of disease. So by the time most of them come to the hospital, it's either very difficult to even diagnose that it's actually yellow fever. Maybe out of 10 or 20 samples, you're able to pick from 1 or 2. All of this, and I think we need to work more on encouraging people to present themselves to the hospital, make sure there is like enough coverage or whatever financial constraints they have, like stopping them from going to see the doctor on time instead of taking whole local medication and trying to even contain things themselves. Let me just stop there.
Thank you.
Merci beaucoup. Comme je l'ai dit, moi, je viens du Togo et les challenges sont assez nombreux. Je vais peut-être les amener d'abord sur plusieurs plans, sur le plan social.
Thank you. Once again, I come from Togo, and the challenges that we're confronting are many.
Alors, sur le plan social, c'est d'abord l'éducation de la population en ce qui concerne les maladies infectieuses.
The first and foremost is the education of the population on what constitutes an infectious disease.
Puisqu'il faudra que la population soit suffisamment éduquée et les bonnes informations, les meilleures informations à temps réel afin qu'elle puisse adhérer à ce que les différents programmes
So we need the population to be well educated and to know real-time information on what's going on for them to be able to
Le second aspect un peu général, donc, c'est ce côté d'accessibilité des services de soins, notamment au niveau des zones les plus reculées.
The second problem would be having access to healthcare in the first place, and that would be particularly in the more outer-lying areas.
Parce que si dans les grands centres urbains, c'est plus facile de voir un médecin, dans les zones reculées, le seul infirmier, c'est lui qui s'occupe de toutes les maladies.
You'll find that in the urban areas, it's possible to go see a doctor, whereas in some of the more rural areas, there might be one nurse that has to take care of everything and everyone.
Alors, quelquefois, la personne est obligée de s'investir sur les pathologies les plus courantes, notamment le paludisme, les maladies diarrhéiques, en oubliant quand même que c'est une maladie infectieuse, notamment le VIH/SIDA et toute autre maladie, parce qu'elle n'a pas les compétences ou elle n'a pas suffisamment le temps de pouvoir faire tout le screening sur les différentes maladies.
Very often that nurse will fall back on the simplest diagnosis. For example, the most common thing would be malaria or some of the direct diseases, but they will exclude then going into things that they might not have been trained for, but it's more complex.
Et donc, le troisième challenge, c'est vraiment cette volonté politique de pouvoir mettre maintenant les services de soins de qualité à la disposition des différents pays. Et donc, qui est un challenge assez important.
So our first and foremost challenge is to make sure we have healthcare available to everyone throughout the country.
Donc, pour moi, au Maroc, là où je vis, le principal défi que nous avons au Maroc, c'est le fait d'inaccessibilité aux soins primaires et aux soins sanitaires pour tous les citoyens.
Morocco, where I live, our main challenge and obstacle is also to have access everyone to primary healthcare and basic healthcare at all points in the country.
Effectivement, les gens qui vivent dans des zones rurales très éloignées n'ont pas la possibilité d'avoir accès aux soins. C'est vrai que le gouvernement il fait des efforts et des fois, il y a même des ONG qui font des caravanes médicales qui se déplacent jusqu'au le coin très reculé. Et les gens, effectivement, les citoyens, ils apprécient beaucoup, mais ce n'est pas suffisant.
And it's true, it's going to be more rural areas, that there will not be healthcare centers available. Or out there, some of the non-governmental organizations, the NGOs will do what are called medical caravans, out there. People greatly appreciate it when they see one of those showing up.
Aussi, il y a un problème au niveau culturel où certains gens, ils ne croient pas beaucoup à la médecine occidentale et ils préfèrent des fois faire des remèdes traditionnels.
There's also a secondary issue, which is that many people do not believe necessarily in Western medicine and would prefer traditional or local ways to pharmaceutical.
Merci.
Thank you.
Thank you so much. Once again, our chair asked about equity in health. Is about, my understanding is how do the people who most need care able to get it in times when they actually times of a pandemic or an epidemic. I want to give the case of my country and the experience of COVID-19. That inequities, I think it's even as we moved around, we saw it, how it happened in the US. In Uganda, for example, if you look at the poor, the bottommost people, during the COVID pandemic, there were restrictions like lockdown. And these poor people use public transport they don't have individual cars, they use public transport to come to the health facilities. So most of them could not come to the health facilities because public transport was either not there or something like that. So they suffered more. So, and that is a serious inequality. So those were chronic diseases, they probably died, quite a number of many. Most of our health systems, because of the COVID pandemic, collapsed temporarily. So there were no patients in the health facilities and the hospitals who are not COVID. The patients ran away from the hospitals, the ordinary patients. So the hospitals became COVID hospitals. We saw this in California, in Cedar Sinai, I think that's the correct pronunciation. When the COVID patients came in, the other patients, diabetes, heart disease, feared going to. And these patients, some of them are very poor. They cannot afford going for an alternative GP, private GP. So you see that a pandemic of that nature affects most a certain group, which is poor or in the lower economic group. So I think it's something that we need as leaders, as scientists to need to think about. If a pandemic of another type comes like COVID-19, there is that class that is low economic, they cannot afford alternative treatment, they suffer the most, and that is serious inequity in health. My area of interest was reproductive health. The mothers who are coming to deliver in hospitals, for example, a hospital that was delivering 100 mothers in a month, delivered only 10. Up to now, I don't know where the other 90 delivered from, because they were nowhere. And probably they delivered in the villages and died. Some died. Antenatal care, they disappeared. Family planning, they disappeared. The doctors did not know how to manage a mother who is going to deliver by cesarean section, but also has COVID. So all these inequalities, they really show us how, as a global population, how we need to think together, how we need to work together and address some of the inequalities that exist. We are told this morning that the predominantly Black population died due to COVID, and we don't know, they refused, they delayed to come to hospital. But those are the issues that really come with these pandemics, and we need to be better prepared for the coming pandemics. Yeah, thank you.
Merci. Le problème de santé que vit la Côte d'Ivoire est pratiquement identique à ce que mes collègues africains ont soulevé.
The issue that we are going through in Côte d'Ivoire are very similar to what my colleagues have already talked about.
Mais je veux mettre l'accent particulièrement sur la rage.
However, I'd like to stress the issue of human rabies.
Parce que chaque année en Côte d'Ivoire, c'est au moins 20 personnes qui meurent de la rage.
Because every year in Côte d'Ivoire, at least 20 people die of human rabies.
Les personnes et les chiens en ville qui gardent leurs personnes, dans les villages, les personnes ont des chiens qui vont chasser, qui ramènent des animaux, mais qui ne prennent pas le soin de vacciner ces chiens.
Well, people in cities have dogs looking after their houses and defending their houses. People in rural areas also have dogs that they take hunting. The dogs bring back animals back to the villages. But these people who own dogs don't have their dogs vaccinated against rabies.
C'est vrai que la vaccination existe. L'État a même réduit de 30% le coût de la vaccination. Mais malgré cela, quand les personnes sont mordues, qu'elles viennent dans nos centres de santé, elles commencent les protocoles, mais elles ne les terminent pas.
So it is true that there are vaccination programs in my country. The cost of a rabies vaccine has been decreased by 30%. However, when people start a treatment protocol, they begin the protocol, but they don't come back to continue it. And so they have no immunity.
Chaque année, nous organisons des activités de sensibilisation et d'éducation dans les communautés pour amener surtout les propriétaires d'animaux à comprendre la nécessité de vacciner les animaux pour leur propre santé, mais aussi pour la santé de la communauté.
So every year we have outreach activities to go to villages and other places in order to try and convince the population that vaccinating their dogs and animals is extremely important for the dog's health as well as for the owner's health and other people's.
Il faut dire que la lutte contre la rage en Côte d'Ivoire est organisée aussi selon les concepts INSEE Santé. Le ministère de la Santé travaille en collaboration avec le ministère de la Santé animale.
So you have to know that in Côte d'Ivoire, we work using the One Health approach. So our Ministry of Health works hand in hand with the Ministry of Animal Health.
Au niveau mondial, le plan d'élimination de la rage est fixé à l'horizon 2030 et la Côte d'Ivoire a aussi son propre plan. Mais nous sommes en train encore de nous organiser pour que cette lutte soit plus efficace pour nous permettre de relever ces défis à l'horizon 2030.
So worldwide, the elimination of rabies should be achieved by 2030. However, in Côte d'Ivoire, we are still a little disorganized and we are still in the process of organizing ourselves in order to eradicate rabies by 2030 and reach that goal. Thank you.
Thank you. So I heard a lot of themes that I want to say unite us all in this struggle. These are also the same things that I work through in my job here in Minnesota, as the Chief Health Equity Officer. Healthcare for everyone being accessible and affordable. Access to hospitals, rural care versus urban care. Willingness of patients to trust the system, come in. Education for the community, ensuring that they understand their options. COVID showed a lot about waiting too long for care because of fear and concern. Economic inequality, causing more disparities. And the idea of Western versus traditional medicine we face here as well. So even though the United States is considered a first world country, we still have all the same issues that second and third world countries all suffer from. We are all united in this struggle to improve healthcare for all. I thank you all for your work. I know the barriers that I face in trying to do this work here. And I've heard the barriers that some of you have shared that you face. What if there were no barriers? What if you had access to everything that you want? What would be the first thing you would do to try and fix the problem? There's no barriers, no money issues, no political issues, no resource options. What will you dedicate your focus?
Thank you very much.
Anne, s'il te plaît, si tu peux le prendre, moi, j'ai pas très bien compris la question.
Entendu.
Oui.
Si vous n'aviez pas de problème de moyens, qu'est-ce que vous feriez en premier? À quel problème vous attaqueriez-vous en premier dans votre pays? Donc, moyens juridiques, financiers, recherche, etc.
Thank you. That would be a perfect word. Hopefully we'll get there one day. For me, the first thing I would do is to make sure there is point of care diagnostic ability for every known infectious disease. Point of care being at the primary health care, and then big tests that have fast turnaround times, because we cannot overemphasize the need to know what exactly is going on at every particular point in time. Because right now, if you go to see a doctor in Nigeria, the first thing is, oh, you have malaria. I'm sure you have malaria. Take medication for malaria. When you treat malaria, it doesn't work, you come back. Oh, I still have headache. I still feel foolish. Oh, go take typhoid medication. And then after typhoid, sometimes you're lucky because if what you have all of those as secondary infection, when you handle all of those things, it helps your immune system to fight the actual infection that you have. But at the end of the day, it might be dengue, it could be chikungunya, it could be anything that we don't know, or God forbid, it might be Ebola. And then you being patient zero, infecting every other person you have in contact with. And before we know it, the whole community is down and then it gets out of control. That is what I will do. We need to know what is going on at every point in time accurately and as fast as possible. And also give capacity to detect unknowns, because there are instances where, a good example is SARS-CoV-2. When the pandemic started, it's happening in China. It has nothing to do with us. Everywhere around the world is a Chinese problem. Thankfully, they had the capacity to detect that, oh, this is a novel virus. And then the whole world took that information and started running with, we now know what this is and how do we build diagnostic capacity. And then by the time the virus started moving around, PCR tests, rapid diagnostic tests, and every other thing, and then sequencing capabilities to know what variant is circulating was already in place. People could do that. So I will build capacity to detect unknown through next generation sequencing ability and metagenomic analysis. And I would make healthcare accessible, because if you're carrying a disease and you don't show up, there is no way for us to know. So, communication to people, make sure they have appropriate insurance that is affordable, and then talk to people. Have, like one of my colleagues mentioned, we learned something about peer-to-peer education. We need to come down to people's level and talk to them. I don't believe in throwing people away just because they think or believe differently. If someone has reservation about what I'm doing as a healthcare practitioner, I should be able to have a conversation with the person at the person's level, or send someone that can reach out to the person, explain the science. And one major lesson that personally I think we should take into COVID pandemic, which I would apply, is as scientists, as experts, we need to be very careful about the statement we make to the public, especially in the heat of dealing with something that is novel. And this has a way of breeding mistrust. For instance, when COVID started, wear masks, don't wear masks. This is understandable, but the public needs to know that the scientific community is giving information as we understand the virus. I also need to make sure that people know that to some extent, viruses have a mind of their own. And if we make strong political statement that, oh, when you do this, don't worry, you're not getting the virus, and people run with it. And tomorrow they do all of that and they still come down with the virus. But I did everything, I got all the vaccination, but they need to know that the virus can mutate. Anything can happen. You need to take a booster dose. And when we don't make those definitive statements very strongly until we have all the data, we'll make them understand that information can change as data is made available. Because all of this has contributed to the reluctance of some people. So there are a lot of things that one can do in a perfect world, but I hope I've listed. So let me hand back to my colleagues.
Merci beaucoup, Judith, pour ces différents éléments. Alors, pour moi, la question, si je n'avais vraiment pas de problème, sur quoi je dois pouvoir travailler? La question qui est posée, si je n'avais vraiment pas de problème, sur quoi je dois pouvoir travailler? À mon sens, c'est la disponibilité des médicaments jusqu'au dernier kilomètre.
Okay, so if I had all the resources to do something, I would make medicine available to the last mile everywhere in my country.
Parce que quand, au dernier kilomètre, l'infirmier, la coucheuse ou la sage-femme a les médicaments à sa disposition, il a le pouvoir d'apporter les services et même de pouvoir être reconnu par la population et d'avoir confiance en lui.
When the medical worker or the nurse working in a remote area has all the medicine they need in order to treat the patient or help the woman giving birth and treat other illnesses, they can help the entire population and also obtain the recognition from the local community.
Je vais juste donner un exemple dans le domaine de lutte contre le VIH. Et jusqu'en 2011-2012, au niveau du Togo, on avait seulement moins de 20% des personnes infectées par le VIH qui connaissent leur traitement et qui connaissent leur statut sérologique.
So I'd like to give you an example regarding HIV in Togo. In the years 2011-2012, only 20% of people infected with HIV knew the treatment they had to take.
Et ceux qui connaissent leur statut sérologique, moins de 30% étaient sous traitement ARV.
And among those people who knew what their HIV status was, less than 30% took a treatment.
Aujourd'hui, on a rendu gratuit le traitement du VIH, donc les ARV, et c'est aussi l'occasion de saluer le peuple américain à travers l'USAID qui a contribué et financé énormément les programmes de lutte contre le sida au Togo.
ARVs are now available for free in Togo, and I'd like to seize this opportunity to thank USAID for their contribution in making those medications available in Togo, contributing to a drastic reduction in the number of very sick people.
La disponibilité des médicaments ARV a permis à ce qu'on dépuce beaucoup plus de personnes parce que les gens savent que s'ils sont dépistés séropositifs, ils peuvent avoir leur traitement. Donc, c'est beaucoup plus acceptable et beaucoup plus facile de dépister les gens.
For people to know that there was an availability of ARV treatments, this helped them and induced them to go and be screened because they knew there was a treatment available and that they could continue their lives.
À ce jour, on a pratiquement près de 80% des personnes séropositives qui connaissent leur statut sérologique. Et ceux qui connaissent leur statut sérologique, pratiquement tous sont sous traitement ARV parce qu'ils ont confiance au système de santé et à la disponibilité des médicaments.
Today, 80% of people who know their HIV status take ARVs, and because they know that the treatment is available.
Donc, la disponibilité des médicaments est un outil essentiel pour le personnel soignant, donc pour qu'il puisse se mettre au service de la population, pour que celle-ci puisse utiliser la qualité. Il y a de la compétence, hein, mais c'est vraiment le manque de médicaments qui fait que les gens n'ont plus confiance au système de santé et vont chercher ailleurs.
The availability of the right medicines is really an important issue, because if the healthcare provider can provide the right medicine to the right people, then the people would have more trust in the health system and in the health provider.
Pour moi, au Maroc, si j'avais accès à tous les moyens, matériels, logistiques, financiers, etc., première des choses que je ferais, c'est de rendre le système de santé public au Maroc plus fort qu'il ne l'est actuellement.
If I had all the resources to do whatever I wanted with the health system in Morocco, I would make it stronger than ever.
Je m'explique. Au Maroc, le système de santé privé, il est très développé.
I meant the public system. In Morocco, the private healthcare system is enormous,
Mais il n'est pas accessible à tous les citoyens.
but all citizens don't have access to it.
Et malheureusement, c'est devenu comme un commerce.
And unfortunately, it's become commerce, it's become trade, money-making business.
Donc, ceci dit, en rendant le système de santé publique plus performant, les citoyens vont reprendre confiance dans leur système de santé. Ils iront aux hôpitaux publics et de cette manière-là, on pourra aussi faire des hôpitaux et installer des hôpitaux dans toutes les zones rurales les plus inaccessibles possibles.
So by making the public health system stronger, we will be able to get people back into going to the hospital when they're sick. They will again trust the public health system, and we will also be able to set up hospitals in remote areas in my country.
Et s'il me reste des moyens financiers, je vais les balancer vers le système d'éducation.
And if there's any money left, then I'll go on to financing education.
Thank you so much. It's a very nice question. I'll use my 20 years of public health experience to approach this question. First of all, I just want to inform our listeners that health is a summation of health choices that you make at individual level or at community level. The moment we get that kind of understanding, if I got all the resources that I needed, back to your question, where would I put them? I would put these resources to focus on the individual and the community. And you not have people in the hospitals. In this COVID experience, the countries that had better community public health systems were hit the least. It was not about money. It was not about money with COVID. The countries that had the best community public health systems suffered the least. And the ones that had money, but the public health system was not good, suffered the most. So for me, if I had limited resources like our resource-limited countries, our major focus would be public health. And in public health, would strongly develop a health education and health promotion programs at community level, even at individual level. All these needs, all the zoonotics are coming from communities. I would also develop data systems or a community surveillance systems that would help us to know in real time how the communities are performing. But if it is going to take you 3 days for you to know that someone has a malaria and he has already infected others, I have a colleague doctor who died in 2008. The first, he was in a hospital and he interfaced with a patient of Ebola. His first thinking was this was worms. You know worms? I don't know if you've heard of worms. He thought because the patient had a rash, he had a fever and diarrhea, and he thought it was worms. He actually wrote a diagnosis of worms. He got infected. He got infected and later died. So if we invested in community health systems, and that's where education, that's where all the diseases and everything, the nutrition we are talking about, health is a product. If you eat badly, you fall sick. If you drink bad water, you fall sick. And all these are happening at community level. And I would also prepare, strengthen the service delivery points. For the few people who will fall sick, you cannot make the world sterile. Some people will fall sick anyway. Those who fall sick must be prepared to handle them. But we must, for any successful country, minimize the number of people who are going to hospital as much as we can. Of course, this involves training the health workers, equipment and PPE, and introducing the equity. So I think that's where our direction will take. Thank you so much.
Merci. Pour moi, si tous les moyens, toutes les ressources étaient disponibles, on pourrait orienter la lutte contre la rage de deux façons.
So should I have all the resources I need, we would be able to focus our combat against rabies in a certain way.
Le premier aspect, c'est l'éducation et la sensibilisation.
First of all, educating and raising awareness about the disease.
Parce que si les vaccins sont gratuits et que la population n'a pas compris la nécessité de se faire vacciner, je pense que tous ceux qui vont se faire mordre contre la rage vont toujours continuer d'aller voir les féticheurs ou de rester à la maison et traiter les plaies de morsure à leur manière.
Well, because I think that if vaccination is free and people still decide when they are bitten to stay at home or go to a traditional healer, then there's a problem.
Et le deuxième aspect, c'est la recherche.
Second aspect is research.
Parce que ce qu'on dit être le nœud du problème, apparemment, peut ne pas être cela.
What we think is the core of the problem, at least at the first glance, may not be.
Le nœud du problème peut être ailleurs, mais à travers des études et à partir des résultats de ces études, on peut mieux orienter la lutte et atteindre le nœud du problème pour pouvoir résoudre définitivement l'élimination de la rage.
Because if we focus our research in the best way possible, then we can find out what the core of the problem is and find the best solutions with the results of scientific studies in order to eliminate rabies as best as possible.
Moi, avec les moyens, on pouvait procéder de cette manière pour être plus efficace.
So I think if I had the resources, this is how I would go about combating rabies.
Thank you. I know that we are getting short on time, and I just wanted to sum up what I heard. I was going to ask the question, how can those of us in Minnesota who are here with you help on this journey? But I think I got the answer from listening to everyone. I think that the help can come from assisting in education efforts, community empowerment, immediate access and resources and tools, and in research support. Did I get that right? Okay, great. Are there any questions in the audience for our panelists? If you have a question, please stand up and say it, and I'll repeat it again to make sure those online.
You forgot exchange of technologies.
Oh,
Yeah, and knowledge.
yes, sharing of technology, that's right.
The question. I'm interested to know what international or multilateral organizations in each country are the most active and what contributions they make.
So the question is, what international organizations are most active in your countries, and what is the contribution that they make? Get that right?
Yes, foundation, international organizations.
Foundations, international organizations, NGOs, which ones are the most prolific, and what is the big contribution that they make? And not everyone has to answer if you don't want to, but if you do.
Quickly, I might not be able to list all of them. For where I am currently, I know we receive a lot of grants from the NIH that allow us to do a lot of research. And because of lack of local government influence in what we do, we're able to have like a lot of output. And you said, is there There are several NGOs that honestly, I didn't even know they were in my country until I came from this program. So, NIH, World Bank, I don't know, World Bank as far as an NGO, but they put in a lot of resources. My country, you say, EPA, CDC is also involved, and we collaborate with our own local NCDC and all of that. Those are the ones I can think of.
Ok, merci. Chez nous, en Côte d'Ivoire, dans le domaine de l'héritage, c'est USAID.
Côte d'Ivoire, for combating rabies, we have the USAID.
Nous avons la FAO.
The FAO as well, Food and Agricultural Organization.
Et l'OIE.
L'OIE,
Organisation de la santé animale.
oh, and the Animal Health Organization.
Ils nous ont accompagnés dans la lutte contre la rage, dans l'élaboration du plan national de lutte contre la rage de 2018 à 2030.
And they are helping us elaborating our national plan against rabies between 2018 and 2030.
À plusieurs reprises, l'OIE a mis à disposition gratuitement des vaccins pour les chiens.
Several times, the Animal Health Organization made vaccines available for free for dogs in my country.
OK, merci beaucoup. Au niveau du Togo, quand tu prends la lutte contre le VIH, la tuberculose et peut-être la planification familiale dont je m'étais cité, donc surtout la lutte contre le VIH.
So in Togo, combating HIV and tuberculosis as well
planification familiale,
as family planning.
80% des ressources dépensées proviennent de l'extérieur.
80% of the resources we spend come from outside our country.
Ce qui montre un peu pour dire, si les partenaires extérieurs disent je ne vous finance pas, comment notre système de santé peut s'effondrer.
It goes to say that if our partners didn't provide us with these funds, our health system would totally collapse.
Alors, en ce qui concerne surtout particulièrement dans la lutte contre le VIH, il y a deux grands contributeurs, le Fonds mondial et l'USAID.
Regarding HIV, there are two major contributors. There are the World Fund against AIDS and the
USAID. Et les ARV, par exemple, quand je prends les ARV et les tests de dépistage, pratiquement 90% des ARV et les tests de dépistage sont achetés par les deux partenaires.
And almost 90% of screening tests and ARVs are bought by those two partners.
Thank you all.
Je voudrais juste rajouter, pour moi, au niveau de l'Institut Pasteur, là où je travaille, je sais qu'on a des collaborations avec le CDC Africa. Et il y a aussi le réseau de l'Institut Pasteur dans tout le monde qui est engagé vis-à-vis du domaine de la recherche.
I could say that for me in Morocco and the Pasteur Institute, that the Pasteur Institute itself and all facilities that are very involved from network and community.
C'est le CDC Africa.
And the African CDC.
I will be brief, the rest I've already mentioned. There are also small funders like foundations that my colleagues have not talked about. They also give direct support to some small NGOs that work at community level. And we really appreciate, especially from the US, there are so many people, philanthropists and people of goodwill. The small support in any way it comes, it helps a given community, like people who contribute through Rotary International. If there are any Rotarians, I'm one of you, and thank you so much. The money that comes in, it fights polio. Most of the countries in Africa have eliminated polio, other than a few cases. And we think that small or contribution you make really changes the world. It means a lot. And Africa has also improved on accountability. Now we account better. Thank you so much.
Merci.
Thank you so much, Dr. Cedarstrom, distinguished panelists, guests here in our audience and around the planet. We're so grateful that you come and join this conversation. It's the beginning of a conversation, not the end. We're thankful to our interpreters, the folks who made our technology work tonight, and to all who keep this library strong and keep our community strong so we can continue to grow and deepen our understanding and make the kind of changes that we've heard about this evening become part of our common human project. Again, merci beaucoup. There's a picture at the very end.
Ah bon? Joli beau. Tu m'as fait photo. Tu m'as fait photo.
Vidéo, chacun a une vidéo, faire une vidéo.
Thank you.
Thank you. Can we do a photo? Yes,
Thank you so much. Just keep that out of your way.
Okay.
Thank you, Lisa. Thank you.